Narcolepsy is a chronic sleep disorder characterized by disruption of the sleep-wake cycle. Patients have difficulty staying awake for long periods of time and suffer from excessive daytime sleepiness and sudden attacks of sleep. At night, they often suffer from insomnia, fragmented sleep, and other sleep disorders. Symptoms can also include cataplexy, which is a sudden loss of muscle tone and control, often triggered by sudden and strong emotion, sleep paralysis, which is distressing paralyzation accompanied by hallucinations when falling asleep or waking up, rapid transition into REM sleep within 15 minutes of falling asleep, and autonomic behavior, which is when patients continue performing tasks while asleep. Narcolepsy typically begins between the ages 10 and 30, and individuals with a family history are 20 to 40 times more likely to develop it. While about 1 in 2,000 people worldwide are diagnosed, this condition often goes unrecognized. There are two types of narcolepsy. Type 1 is when it presents with cataplexy, while Type 2 is when it manifests without. This disorder is thought to be caused by low orexin levels in the brain, stemming from the loss of orexin-producing neurons. In fact, there's a 90% reduction in orexin-producing neurons in Type 1 patients. Orexins, also known as hypocretins, are neuropeptides that stabilize sleep and wake states by suppressing REM sleep. Orexins also serve many other functions, such as increasing sympathetic tone and motor activity, which could explain the cataplexy. They're exclusively produced in the lateral and dorsal-medial hypothalamus and are widely projected to the rest of the brain. While the loss of orexin neurons is poorly understood, one prominent theory is the autoimmune hypothesis, wherein narcoleptic patients have an immune dysfunction, resulting in the destruction of orexin-producing neurons by autoreactive T cells and B cells. About 95% of type 1 patients have the HLA allele polymorphism, MHC class II DQB10602. This gene encodes the antigen-presenting molecules that instruct the T cells to target pathogens. People with this gene variant will have an orexin-binding pocket on the molecule, allowing it to be targeted by T cells. Also, evidence suggests that the T cell's response to infections, like H1N1, may cross-react with the orexin peptides in people with this allele variant. Furthermore, the autoantibody TRIB2 is correlated with narcoleptic symptoms, like cataplexy and sleepiness. These antibodies will react with orexin-producing neurons, marking them for destruction by the immune system. Like many CNS disorders, there is no cure for narcolepsy, so the treatments are symptomatic. Although improvements to sleep hygiene are recommended, pharmacological treatments are also available. Once diagnosed, clinicians will likely start with stimulants. Modafinil and armodafinil are mainstays, alleviating daytime drowsiness, and are less addictive than older stimulants. Armodafinil has a longer half-life than modafinil. Side effects are not common and generally mild. Newer drugs include the H3 histamine receptor antagonist, pitolisant, which helps alleviate cataplexy and daytime sleepiness. For more severe forms of narcolepsy, amphetamines, like dexamphetamine, may be prescribed. These drugs are powerful and effective treatments, but carry the risk of addiction and more severe side effects. Sodium oxybate is a fast-acting sedative and is extremely effective at suppressing cataplexy. It improves nighttime sleep and limits daytime sleepiness at high doses. It also has an additive effect with modafinil, and both are generally well tolerated. However, it does have a sensitive side effect profile, and drug-drug interactions are a known risk, thus requiring medical supervision. Antidepressants can also be prescribed, though their efficacy is still under study. SSRIs and SNRIs suppress REM sleep, thus alleviating cataplexy and sleep paralysis. However, there are side effects. Most improve within a few weeks, but some may persist. Tricyclic antidepressants, such as protriptyline, are used to treat cataplexy, but they have significant side effects. New drugs are presently under development, such as the orexin receptor agonist TAK-861 and GABA B receptor agonists. These new therapies provide avenues for novel treatments and could lead to a cure.